Hi, I'm Dan Anderson, and this is my project for ANTH 412, the final proposal presentation. My preamble for this project is that the idea came from psych nurses at Cascadia Mental Health. They pointed out that dual diagnosis individuals with schizotypes, schizophrenic traits, and addiction are often highly spiritual individuals, and addiction and spirituality are common cofactors in mental health crisis situations. So on that note, the statement of purpose for my project is that narratives of crisis involving spirituality, substance abuse, and mental stability, mental health, should be recorded and analyzed, and the results should be published. That type of project would be beneficial in specific clinical settings and would give a public voice to a misunderstood phenomenon, I think. I'll undertake 4 months of field work with 15 persons identifying as highly spiritual and 10 psychiatric care workers who have worked in crises. The central aim is to augment and critique the psychological literature that I've found on this topic, which I'll go over, and to publish the information I find on personal experiences of crisis for use, at least for consideration by family members of people who may be in mental health crisis and for clinical professionals, and also for people who may be having a mental health crisis. So in the review of the literature for illness narratives is where I begin. These are personal accounts of illness experience, and they describe a specific event or a chain of events and the cultural meanings associated with the outcomes of those events. They are used socially to try to make sense of events and to affix blame and responsibility. And for the interviewer, they can indicate shared cultural knowledges. I'm looking at crisis narratives, which are illness narratives focused primarily on a crisis event. Let's get a definition of spiritual on the table since I'm talking about that. I'm going to look at it as a specifically subjective and experiential aspect of a mystical perspective that can be sought and experienced by traditionally religious people and non-religious people. It's an experience, it's transcendent. So it's related to non-mystical aspects like well-being, so it can be a coping system, but it's not defined by them. I follow a lot of literature in using the mystical preference or mystical seeking as a spiritual definition. In psychological literature, as I said, there is literature on the subject, and recent studies show clinical measures of spirituality correlating positively with self-reported frequencies of drug use, as well as the likelihood of actually a lot of different kinds of mental disorders. And that is comparatively to less spiritual people, even people who are traditionally religious, but just not as spiritual. So, looking at the concept of medicalization from Conrad, turning a social badness or a personal badness into a sickness through social processes. Ontological politics, what are the social processes that make something real? What are the politics behind this is spiritual and this is mental? Who draws that line? And then looking at the model of healthcare systems from Hans Baer and others on the interactions between different levels of power and influence on the person in the healthcare system. For example, you can study family level interactions with medical authorities and the healthcare system. And I'm going to be using those theories in the analysis of the data that I have, focusing on the agency of the people, because this is a largely stigmatized and oppressed characteristics of people, if not stigmatized and oppressed demographics being worked with. And so to stay focused on these people as making choices within their daily lives, rather than being victimized totally by the structures they live in, to keep them represented as making choices is very important according to a lot of authors, and Hans Baer, and I definitely agree. So in my focus on agency, I'll be drawing on Meryl Singer and Hans Baer's work, as well as Dr. Klein's from PSU, and Dr. Kulik in that paper. That's work that deals with identities used during crisis. My research site is the Portland metropolitan area, the least religious metropolitan area in the country. Low religiosity compared to the national average, regionally and in the city, but high spirituality in the region and in the city in non-traditional ways like New Age spirituality, earth worship, unaffiliated spiritualism, and millennialism. Very interesting topic I don't have time to go into. The opportunity is there, I think, to study an eclectic range of spiritual beliefs in a relatively small area. So I did a 10-week pilot study in the inner city neighborhoods of different quadrants of Portland, Oregon, in people's homes, in bars, in libraries, did some phone interviews with both demographics, clinical workers, and highly spiritual laity, and the data strongly supported the hypothesis, which I will lay out momentarily. And this recommends expanding the sampling for the test, moving into different neighborhoods, expanding geographically as much as is possible. I feel I've gained a high level of rapport with informants, especially because I have lots of invitations to follow up, and introductions have been offered for more interviews. So for research design and methodology, going to double the sample size through a snowball sample out of the current sample from the pilot project, minimize social connectivity in that group through analysis online through social networks like Facebook, with permission, of course. I think that's a good way to make sure that what I'm not really testing here is the cultural domains of a social network, rather than a somewhat representative sample of the region. And this will mean, obviously, spending time being selective in my informants. That will be a challenge, and I think an interesting technical endeavor for this project. So group 1, 15 persons identifying as highly spiritual. Group 2, 10 psychiatric care workers who've worked in crisis. I'm going to do 2 basic kinds of analysis: intergroup variation and intra-group variation in both narrative and cultural domains. So the central hypothesis is that consistent discrepancies will exist in how crisis, especially crisis involving mental illness, is conceptualized relative to spiritual beliefs and class demographics. What are covariations in conceptualization and class demographics? And the same is true for how crisis is negotiated, how it's engaged, and how it's communicated. The second hypothesis is that shared cultural notions of spirituality will be used and engaged in the form of identities and information during crisis for both coping and strategizing within the power structures people live in. An example of that is from my field work, people's use of religious identities as kind of power cards in a negotiation, and that draws on Dr. Klein's work. So for the first of these 2 analyses, we're going to use a 2-group post-test only design with non-random assignment, obviously between the clinical and the laity groups. We're going to identify shared and not shared cultural domains as best as possible, and narratives, themes within the narratives relating to crisis, relating to spirituality, relating to mental health, and related to altered states, to drug use. And that's going to be in both crisis and in everyday life. So for intergroup cognitive variation, and that is only among the laity population, we're going to do a multiple group post-test only design with non-random assignment and compare demographic subgroups that are observed within the laity population. Now, it's a small sample, but if we can get some variation and some covariance with spiritual aspects and demographic aspects and other measured aspects, that will be enough to analyze, according to research scholars like Russell Bernard. You only need about 10 or 12 people to really understand a cultural representation or domain if you have a representative sample. Questions in this type of analysis, I actually used this in my pilot project. Is this supernatural information ever totally wrong? And that's when I was discussing supernatural revelations with several people. A question like that might inform a domain like supernatural concept if we're talking about how do people conceptualize this, and we can use an in vivo label to name how people refer to that. So for ethics, obviously it's a vulnerable population, sensitive subjects being discussed, stigmatization in society for drugs, for mental illness, and in some cases for spirituality. That's why I'm always going to obtain informed consent, use pseudonyms throughout the project in field notes, as well as destruction of the data after the project if the informant asks me to, definitely keeping the name anonymous within the data, and also deliver the final product to the informant to read with them if they want, and offer the opportunity to respond on tape or in writing to me personally. So the significance of this data, again, it's a small sample, but we still can infer the existence of shared cultural domains in this population. So scenario 1 is complete failure, and that is crisis is conceptualized in a homogeneous way across all spiritual views and demographics. We don't find variation. That probably won't happen. Find variation of mental health conceptualizations among actors static compared to spirituality and demographic variation. We don't find anything. In that case, I would have nothing to critique the psychological literature about, or to augment the psychological literature with, or to really offer to anybody. And it would be Edisonian progress reported in the paper, just reporting, hey, we know this isn't true. For a hypothesis partially supported, it's more likely, I think, crisis and mental illness might be conceptualized a little bit differently across different spiritual views in a somewhat consistent way. For example, a question like, when is this a spiritual problem versus a medical problem? That answer might change in a predictable way across relative to some demographic cluster. In this situation, negotiation of the crisis, for example, would vary relative to spirituality and demographic variation. In this case, psychological literature could be augmented, critiqued, commented upon relative to my data, and the paper might be able to suggest something about crisis engagement with spiritual individuals in a mental health centered crisis. In this case, the psychological literature would receive augmentation and critique relative to my data, and the paper could suggest specific things based on the data to people who engage crises. Fundamentally, this project seeks to deliver whatever quantitative data it comes up with in a critical, qualitative way based on that literature. Data should be presented as focused on humanization of these stigmatized conditions, and that's the role that the theories of medical anthropology play here. I want to do this explicitly through using the theory in the write-up, and also intrinsically, as I've described, through the use of in vivo coding and grounded theory to interpret and explain the interview data and the cultural data. In conclusion, my project focuses on informant agency within structures of culture and the state, while quantifying valid information on the experience of the sufferer's crisis of genuine value to those interested in offering truly compassionate care. My pilot field work over the last 10 weeks has put me in touch with an ample and willing population and given me the skills to interview them and analyze the data toward the goals of this project, which I think are worthy. Thank you.